Hi, everyone. My name is Vincenzo Berghella, and welcome once again to another live event here at Edgegam FM. I'm joined by Anna Angarita. Anna, thank you for being with us. Why don't you introduce yourself?
Thank you for having me. I am, as Dr. Berghella said, I'm Ana Garita. I'm one of the third year fellows at Thomas Jefferson, and I am heading after to Jefferson Einstein in Philadelphia.
So, we're going to do third stage of labor. This is part five of our series. We did induction, before labor, first and second stage. Now we're up to third stage. Um, Thanks, Anna. I don't know if you want to say anything about the paper, but it was certainly a work of love, and thank you again for having done so well with that. You can all read it, and next we'll do postpartum actually in the next couple of months. But for now, today, third stage of labor. So to start, I think that one of the main messages is that based on large meta-analysis, as you can see at Cochrane from 2018, at the bottom of the slide there, other meta-analysis of thousands and sometimes hundreds of thousands of patients, it looks like compared to oxytocin alone, combination like oxytocin and Tranix, oxytocin and misoprostol, and oxytocin and Metrogen, are superior, as is carbetocin alone. As you can see here, level one evidence that they're more efficacious than oxytocin alone, for example, in postpartum hemorrhage. And this is important. Carbetocin, unfortunately, is not available in the US, but it's available in many countries, and it's the first line, I believe, in Canada and many other countries around the world. It's a little bit more expensive, but works well, and it's well worth the cost. But for us in the US, combination, as we'll go over multiple times, seems to be better at preventing postpartum hemorrhage. I want to say actually that we will talk today about prevention, not about treatment. And we did this Edgegam FM series mostly about prevention, which I think it's not talked about enough. Don't wait for somebody to bleed away, just try to prevent it. In terms of oxytocin and misoprostol, there's also significance in terms of less need for additional urotonics. Maternal death, ICU was similar. And obviously, sometimes if you have combination of medication, for example, oxytocin and misoprostol, obviously may have some doses, and we'll review the doses later on, a little bit more side effects. And that's why I personally like a lot oxytocin and tranexamic acid, which is the one that really doesn't give any side effects. So you see the alternatives here in the table.
So in terms of the route of oxytocin, and again, just to remind everyone that this is all the slides are about term vaginal deliveries and prevention of postpartum hemorrhage. So in terms of intravenous versus intramuscular oxytocin, when we use intravenous, that decreases the risk of postpartum hemorrhage, defined as more or equal to 500 milliliters. Also decreases the risk of blood transfusions. And if you compare IV infusion with IV bolus, it decreases postpartum hemorrhage and additional uterotonic use. Again, as we mentioned before, with oxytocin, with combination regimens, you can have an increased risk of adverse effects. With intravenous, one of the concerns, especially when you use a bolus, is the risk of hypotension. But the trials and the meta-analysis didn't show an increased risk of hypotension when we use oxytocin intravenous or bolus when compared with intramuscular. And of course, if you have no IV access, the recommendation is to use 10 units of oxytocin intramuscularly.
And one quick comment: this has changed over time. IV seems to be superior. In the past, trials were not as extensive, and say that maybe the two were equivalent. In fact, around the world, especially in low-income countries, IM is used routinely and works pretty well. And usually don't need an IV even for labor. You can just give it IM. But when compared now with much more trials, IV seems to be superior. And the dosing, it's, I would say, a little bit controversial. There's some evidence that you need to give at least 10 units. Some trials give even 5 units, and that's too little. But again, the data here is that there's not much difference. It's interesting. At Jefferson, I believe, Anna, we use 30 units for, like you said, a term uncomplicated vaginal delivery in the first bag, run widely, and then 30 units in a second bag, run at 125 an hour. And, there's not as much evidence that that works, but I think my impression throughout the world is that a lot of people use more than 10 somehow.
In terms of timing of oxytocin, and in terms of administering the oxytocin before or after the delivery of the placenta, when we administer oxytocin before placenta delivery, there's actually no differences in terms of all these outcomes mentioned here. In terms of postpartum hemorrhage, no difference in blood loss, in use of additional uterotonics, blood transfusion, length of the third stage of labor, and one of the concerns that is retained placenta, especially when we give it before placenta delivery, there's no change. One randomized control trial did show a decreased third stage duration when we give the oxytocin before placenta delivery. So our recommendation is to administer the oxytocin before placenta delivery, either after delivery of the anterior shoulder or the neonate's whole body.
And I know you and I have discussed this at length, and maybe plan other studies on this. The other day, asking residents and nurses here, I think mostly we give the oxytocin at the anterior shoulder, and there may be some evidence that may work well, but they're certainly not definite. And so, if people are looking for research studies, I think that's a good research study looking at anterior shoulder oxytocin timing versus after delivery of the baby. And some of the studies show that the sooner you give it, the more retained placenta you may have, but also the more efficacious it may be at preventing it, as it may make sense. But that's still more opinion than truth. So Anna reviewed oxytocin. There's also prostaglandin F2 alpha, for which, as you can see here, there's really not as much information. The meta-analysis below, it's all of the trials, but really not as much. And as you can see here, it can work for treatment, and we use it a lot, as obviously if somebody's bleeding, but for prevention, the limited information there, it may not work as well. And that's why we don't give it for prevention. And it's not part of the combination we're talking about today.
In terms of the combination of tranexamic acid and oxytocin, again, this is term vaginal deliveries for prevention. When we compare that with placebo plus oxytocin, when we use the combination regimen, there has been reported a decreased risk of postpartum hemorrhage. This was defined as more or equal to 500 cc's within 24 hours of delivery. And also there was a decrease in mean blood loss in one of the meta-analyses that included 4 randomized controlled trials. And one of the concerns is the risk of thromboembolic events. Most of the trials, they are not powered to show a change or an increased risk of thromboembolic events. But there was a very large meta-analysis that included 216 randomized controlled trials. And that included all medical and surgical disciplines, and it didn't show an increased risk of thromboembolic events when we use tranexamic acid. So if you are going to choose oxytocin and TXA for postpartum hemorrhage prophylaxis, we recommend using IV TXA 1 gram plus IV oxytocin immediately after delivery of the neonate.
And the dose, some trials use 1 gram, some trials use 10 milligram per kilogram. And, one of my comments would be that in general, 1 gram works well and it's well studied. And again, this is a vaginal delivery, so, right after the baby delivers. But, if you have somebody who's particularly obese, you could certainly consider giving more by using the weight-based 10 milligram per kilogram. Misoprostol and oxytocin, I think in the US, it's probably my second favorite combination after Tranix and oxytocin. I think 400 microgram, it's kind of a in between dose that you give enough so that it prevents postpartum hemorrhage and blood loss, and maybe there is less side effects like fever. That will be with 600 micrograms or 800 micrograms. But clearly depends on the scenario you have. And as we'll discuss later on, this is becoming more and more common, especially if you have somebody, again, you're preventing postpartum hemorrhage and maybe has a prior postpartum hemorrhage risk, is delivering twins, and has maybe had a risk factors like gram multiparous for postpartum hemorrhage.
In terms of methyl argometrine, so using the combination regimen with oxytocin, the dose would be 0.2 milligrams IM. When we compare that with oxytocin alone, the combination regimen also is associated with decreased postpartum hemorrhage, but there was no difference in terms of postpartum hemorrhage with the new definition of more than 1,000 cc's. There was also no difference in terms of blood transfusions or hemoglobin change when we compared that to oxytocin alone. Of course, when we use the combination regimen, there's an increased risk of nausea and emesis. And also when we use methyl argometrine, there's an increased risk of hypertension.
So again, I think this is a good combination, but it's maybe more side effects than some of the other ones, especially Tranix and oxytocin. And corbetocin, as I say, if I were in another country where the regulatory bodies would approve it, I would use it. The FDA unfortunately has not approved corbetocin, but at this dosing has been shown to be better than oxytocin alone in terms of postpartum hemorrhage prevention, and has very little adverse effects, kind of like oxytocin. And so if you have it available, I know many people look us on Facebook and Twitter and YouTube and LinkedIn, etc., from around the world. Feel free to use corbetocin as one agent, certainly better than oxytocin.
Now, talking about control cord traction. So when we compare that with no control cord traction, that we know this is one of the parts that we use in the active management of the third stage of labor. Using the control cord traction decreases the risk of postpartum hemorrhage, decreases mean blood loss, decreases the duration of the third stage of labor. And there was no change in terms of postpartum hemorrhage more than 1,000, need for additional uterotonics or blood transfusion. We do recommend using control cord traction after delivery.
And obviously we need to be careful. You want to do it gently. You don't want to pull on that cord too much and avulse it and leave a placenta inside of it. Then you have to go and manually remove. But the evidence wasn't there, I think, 20 years ago. But now you can see the evidence at the bottom. It's pretty obvious that gentle control cord traction, it's beneficial. And delayed cord clamping also, as you know, has become. It's something relatively new as well, has become more common, increases mean birth weight, hemoglobin concentration. It does, as the one side effect, increase neonatal jaundice, but it's usually a minor side effects. It improves iron deficiency. It's not associated with major other changes, but the fact that hemoglobin is better, iron deficiency doesn't occur as well, has been shown to be beneficial. And as you know, in preterm babies in particular, it may also be, in some studies, associated with less intraventricular hemorrhage, which would be a major benefit. So we do it routinely here in Philadelphia, usually 60 seconds, and it's well tolerated. Again, we have neonatologists for the jaundice and a little bit of lights, which doesn't happen often at all. Can be well managed.
In terms of umbilical cord milking, which entails like a rapid transfusion of blood from the placenta to the baby while expressing the cord in a rapid manner. And the rationale is that when you do this, you provide blood transfusion to the infant faster so that maternal or neonatal resuscitation can happen as soon as possible. When we compare this with immediate or delayed cord clamping, in this study, sometimes they define delayed as like 30 seconds or 60 seconds. There has been an increased risk of hemoglobin at 48 hours or 6 weeks of life, and no changes in terms of the peak bilirubin level or need for phototherapy. However, in the larger meta-analyses that included 10 randomized controlled trials, there was no change in hemoglobin. And there was one randomized controlled trial that included preterm infants. They were between 23 and 27 weeks that showed an increased risk of severe intraventricular hemorrhage when we did umbilical cord milking. So that trial had to be stopped prematurely in that setting. So there's not enough evidence to support or not recommend using cord milking.
I'm curious. Have you ever seen it? You trained at Hopkins.
No, I have. No, I have never seen it.
Yeah. I've seen it in the past. But certainly we haven't done it in many years. Given delayed cord clamping seems to be so efficacious and safe.
Yeah.
This I couldn't believe. When we did this study, we only found 3 randomized studies evaluating massage, basically, versus no massage, assuming we give also oxytocin and control cord clamping, and that adding urine massage to what works, oxytocin and control cord clamping, really, these studies couldn't find any benefit. It's only 3 randomized trials. I'm not telling you not to do urine massage, at delivery in an uncomplicated, term delivery or other deliveries. But it's interesting that the evidence is not there. And we'll talk about C-section, later on in the year. There's actually 0 randomized trial evaluating urine massage at C-section. So again, something that people do routinely, and again, ideas for future studies. There's a question about, would the recording be saved? I assume Dr. Trang, yes, it is saved routinely on Facebook and Twitter and YouTube and LinkedIn.
In terms of nipple stimulation, so the rationale is that nipple stimulation increases oxytocin, that increases contractions, and that would decrease the risk of postpartum bleeding. When we compare this with oxytocin, there's really very limited data. There were only 2 randomized controlled trials that we could find. And then there was no change in terms of blood loss or postnatal anemia. So again, there's insufficient evidence to recommend this.
So we're going to switch gears a little bit. Postpartum hemorrhage prevention, I think, is the mainstay of the management of the 3rd stage of labor. And I hope today you get an idea that 3rd stage of labor is really, really important. Again, postpartum hemorrhage is one of the things that continues to be around the world kind of on the top of the list of causing maternal morbidity and mortality. So really important to prevent it. But there are other things that we don't focus as much as well on, like managing, in particular, vaginal and perineal lacerations. You can see a quick review of 1st to 4th degree. Later on, we'll show you the ACO classification. These slides begin to assess the fact, should you even repair a limited, non-severe, meaning 1st or 2nd degree laceration, perineal lacerations. And in particular for 1st degree, there's really limited evidence that repair does anything in terms of better outcomes. So some people, including midwives, certainly some of our midwives here, say that and I've seen them leave mucosa only vaginal tears alone without repair. Usually from 2nd degree on, people repair them and probably should repair them.
Yeah, and I feel that I have noticed that, especially if the 1st degree is hemostatic, there's no need for repair. In terms of 1st degree laceration repair, using glue versus like standard suturing, using glue has been shown to has shown to have decreased mean repair time, so it is faster to repair. You have less need for local anesthetic, less pain, and there's no change in wound complications or patient satisfaction. So something to consider, but we don't have enough information for recommending glue. I personally have never seen it done.
Yeah, me neither. But again, look forward. Some of this is to give new ideas, to our audience. In terms of how you repair it, and this information is mostly on second degrees, which are the more common ones that we, repair probably. Our incidence of third and fourth degree, I know Jefferson is less than 5%. Hopefully, that's the same in your places. So most of the time, you're dealing with a second degree you're repairing, and if you do it continuously versus interrupted sutures, there is less pain, less need for analgesia, less need for suture removal, and as you can see, other outcomes are similar. So since this is actually one of the few things under the sense, in the last 30 years has not changed. As a resident, I used to repair this once continuously, and we can still do that.
In terms of third degree laceration repair, so we know that there are two techniques, overlap versus end-to-end. Overlap, when we compare that with end-to-end, there hasn't been any change in perineal pain, dyspareunia, flatus incontinence at 12 months. However, in the meta-analysis shown there of 6 randomized controlled trials, there was a decreased risk of fecal urgency and lower anal incontinence in the overlap group at 12 months. So just something to consider, but both are recommended.
It's interesting. We heard you and I recently that colorectal surgeons actually use the overlap technique to do repairs. Obviously, non-pregnant adults, men and women. So again, I'm used to do the end-to-end, but there's certainly some obstetrical literature that you just showed that end-to-end may be beneficial, and there's also non-obstetric literature that may be in the future what to do more often. And there's really not much of 4 degrees, again, usually 1% or less, hopefully, unless you're doing lots of forceps and vacuums, maybe in other countries than the US. Delayed absorbable, vicryl or chromic, usually running. You can also and reinforcing a layer through the rectal muscularis layer using a trio, again, vicryl as well in running or interruption is what ACOG, for example, suggested, but there's really not good large randomized studies, probably because thankfully this is rare. But it's really, really important to repair it well, repair it in layers. And and these individuals unfortunately can have long-term consequences. So it's actually good to ask for senior help when you're taking care of these, and to also follow up and make sure that they don't have any flatal or incontinence later in life.
And in terms of what sutures to use in your repairs, when we use standard synthetic sutures, that is the polygalactic vicryl versus catgut, there's decreased short-term pain, decreased analgesia up to 10 days postpartum. You have less superficial wound dehiscence. You have an increased risk of removal of unabsorbed sutures when you use the standard ones. Of course, when you use the catgut, you would have a higher risk of resuturing. And then there was no difference in terms of wound breakdown. So the recommendation is to use the standard synthetic sutures that I feel that's what almost everyone uses.
What do you usually use? What's your...
Vicryl.
Yeah, like trio or...
2 or trio. I feel that at Jefferson, I have noticed that they use the rapidly absorbing one that I didn't use in residency.
Okay. And I'm noticing you're wearing pink. Thank you for doing that for the Pink Journal. So then in terms of suture, again, comparing or standard suture versus rapidly absorbing, same outcomes in terms of pain and dyspareunia, but increased suture removal in the standard synthetic suture group. Any comments on this slide, on this particular analysis from you, Anna?
No, there was a lot of a very large meta-analysis, and yeah, there was no no difference. So I have seen people use the standard one or the rapidly absorbing.
Okay.
Uh,
So you think they're both okay, I guess.
yeah.
Yeah.
In terms of giving or not antibiotics when we are repairing a third or a fourth degree laceration, there's very limited data. We could only find the randomized controlled trial of 147 patients. They received second generation, just one single dose of second generation cephalosporin, and that showed a decreased risk of wound disruption and purulent discharge at 2 weeks after delivery. However, in that randomized controlled trial, there was a high loss to follow-up rate. So something to consider. It is something that I do when I repair a third or fourth degree laceration.
And this is ACOG thing to just wrap up, the suggestions. We wanted to show you the level 1 data. This is, the opinion, based on data as well, obviously, from the Committee on Practice Bulletin on Obstetrics of the American College of OBGYN. Similar, first degree considered a repair, and then what we discussed in terms of, repairing first, second, third degree, and there's 3 different kinds, and fourth degree there. Really an important topic, and not only for, short-term help, but also for, long-term function.
Now changing gears again, in terms of skin to skin within an hour versus no skin to skin, that has been associated, as we all know, with increased risk of breastfeeding at 1 to 4 months after birth, and also duration of breastfeeding. So it is recommended to do skin to skin. And that meta-analysis was included 38 randomized controlled trials. So it was a very large study.
I was in house calls, this Saturday. It was just, it's almost like a second-hand thing. Baby comes out, boom, just goes into mom's belly, even before we cut the cord. In fact, at least that's what I saw this weekend, and it's a beautiful thing. Mom can breastfeed more, and then the baby actually comes down, many times, and just feeling the warmth of the mom's skin, skin to skin. Truly, don't make sure there's nothing in between. Third stage duration, there's always been 30 minutes. Again, that's something that has stayed throughout my training and adult professional life, I suppose. And that's based on some of this data that you see here. It's really, the placenta should deliver, so again, time from delivery of the baby and deliver the placenta, that's the third stage. It's usually about 5 minutes, 5.5 minutes, as you can see there. And 90% of the time within 9 minutes, which I think are good numbers to keep in on time. So while you sometimes wait more than 30, even at 15, 20 minutes, you may be in a little bit of trouble because 90+% of those placenta should have delivered. And unfortunately, the longer it lasts, the more risk of postpartum hemorrhage, and something that you need to be aware of. So I think that prophylactically pulling on that cord, giving the oxytocin, giving a second agent, trying to get the placenta out, it's helpful.
In terms of core gases, should we do selective sampling or universal sampling? There's not a lot of data. There's no randomized controlled trials comparing these. But when we use selective sampling, that increases the chances, of course, of missing samples if we're not collecting them all, especially in high-risk deliveries. So there's insufficient evidence to support universal sampling. At Jefferson, we do selective sampling of gases.
Yeah, when I was a fellow, when I was you, and many years ago, we used to do universal. One of the chairs, for medical legal reasons, I suppose, kind of felt, let's collect gases, and most of the time they can protect you. Maybe a baby is not doing so well, but you can prove that the pH is normal, the base excess is normal, etc. But then we went to selective, and I think there's really no, like you say, no big evidence for or against. So whatever you do is probably fine. And more studies probably were needed. This is something that happens only maybe once or twice a month, if at all, here in our unit with 3,000 plus deliveries. Umbilical cord private banking, it's really not recommended. But public banking, if you have a public bank available, there's one nearby here in New Jersey. It's good, and it's recommended by ACOG. Make sure that you get, you collect it safely, aseptically, and with an adequate amount. It really doesn't cause um, any issues in terms of side effects to the mom or the baby, um, even with the leg core clamping, as you can see from the data. So if you're near and you're working with a public bank, I'm all for bulk core blood banking that somebody else in the future can use. But if you're doing it for yourself or for that baby, or for her siblings or his siblings, the incidence of needing that is extremely low, less than 1 in 3,000 or something, and therefore we don't encourage it. But certainly, again, the few patients we have, we do it for them.
Briefly, just take home points. Consider using tranexamic acid 1 gram within 10 minutes after delivery of the anterior shoulder or the baby's whole body. Use combination agents, especially if it is a high risk vaginal delivery, oxytocin, misoprostol, or oxytocin metrogyne. Continue doing delayed core clamping, core traction, and there's not a lot of information about uterine massage.
Yeah, I underlined the first couple of bullets because, daily core clamping, I think it's common. Core traction, we've been doing forever. Uterine massage we'll probably continue to do, even if, as I say, there's really no evidence that it helps, as studied at least so far. But the changes is adding something else to oxytocin, and when do we think do we do it at Jefferson on a vaginal delivery? When are you seeing that done more?
I have used it and I have seen TXA being used when it is like a high risk delivery for prevention. And oxytocin and miso, I would say as well, like for prevention when we see a patient that is like grand multipara, or a patient that has been in labor for a long time on magnesium. Those are the patients that I have seen that we use the combination agents more at our institution.
Yeah, I'm thinking chorioamnionitis, maybe, there's many things. I mean, the data we showed, I want to make sure people understand. The paper we show are, low-risk patients delivering a term, like you say, a vertex baby, normally grown, etc. And as we showed you, it works, adding something else to oxytocin. But I think, changes take, 15, 20 years to take effect, even based on the evidence. And while I think we have the evidence in 2023, we're slowly changing, and the slow change has involved, at least here in Philadelphia, the higher risk patients getting a combination of oxytocin and tranexamic acid or oxytocin and miso.
Mhm.
Any other last thoughts you have before we wrap it up?
No.
Yeah, thank you for your help. It's really important. We have done lots of these. Live at Age of FM. I just wanted to show you the list. This is like today is like the number 20th or so. We've done lots about labor, as you can see, also ultrasound and manual rotation by themselves, since there's so many great news about that. We did obstetric topics, twins, progesterone, steroid timing recently. We did other things like, looking at obstetrical RCTs, COVID vaccine in the past, like we did the parity inclusion. We looked at how you go from idea to publications. Our AJOGM-FM fellows did the review process a couple of times, actually. We also looked most recently at ACO guidelines and the references. And all of these are done live, as we're doing today, on Facebook, Twitter, YouTube, and LinkedIn. But then they stay there. As soon as we close in a few minutes, they stay there for forever, quote unquote. And so you can watch them at any time if you don't get to watch them live. You can watch, here are some of the accounts, the Pink Journal Twitter account, the Pink Journal YouTube account. You can also watch them on my accounts. And certainly you can ask questions, as some did earlier on, and you can certainly email me for any questions or topics. But I'm very proud of what's going on at the Pink Journal, and I want to thank all the authors sending such great research in. As I say, probably recently, we now get 100 some papers a month, which is amazing, and some of the best research done on pregnancy and pregnancy complications. And because of that, we're actually going to do another couple this month on March 24th at 4 p.m. Eastern. Hopefully, you can watch from wherever you are in the world. We're going to do a very important topic that we feel very strongly about at AJOG-MFM, gender issues in obstetrics, be it in academia, at SMFM, publications, career, etc. And we have about 5 amazing presenters lined up already for that. And then there are a couple of major papers that came out, one in AJOG-MFM, one in AJOG, about timing of induction in term prom. And really the message is going to be induced, right away, as soon as you can, once you have pre-labor rupture membrane at term, based on now large databases, analysis of randomized trials. And we'll do that on March 27th, 2023 at 3 p.m. I want to thank everybody for being with us. Anna, you want to say the last bye before we close?
Thank you, everyone, for joining.
Bye-bye.